Hi, class. This is Dr. Weaver, and I am going to have a discussion with you about leukemia. There's so much to discuss with respect to the various disease conditions. For the next test, we will be looking at blood disorders and also, what is the other one? Renal issues and what have you. And so, in order to spend a little more time on the more complex issues in class, I thought I should go ahead and produce another voiceover for leukemia, a fairly straightforward disease condition, so you shouldn't have too much difficulty understanding the concepts and principles related to leukemia. Now, leukemia is a cancer that results from a loss of normal cellular regulation leading to uncontrolled production of immature white blood cells, also referred to as blast cells in the bone marrow. So when you think about all the functions that occurs within a cell, what happens with these white blood cells, they are immature, and the cellular function that essentially, or shall I say, ultimately leads to homeostasis because of all the regulating functions within the cells, they become, how can I say it, they become abnormal. They're not able to function as a normal white blood cell. And of course, as we know, white blood cells, one of their main functions is to fight infection. And of course, when a white blood cell is immature, it cannot fight infection. And of course, your white blood cells, as well as your red blood cells and platelets, are actually produced in the bone marrow. The bone marrow becomes essentially overcrowded with these immature cells. So they're non-functional cells, and production of the normal cells are greatly reduced. So red blood cells, platelets, even some of your white blood cells, they are greatly reduced due to these immature cells that proliferate, or they increase significantly in number. This condition can be acute or chronic. Now, as I mentioned, white blood cells help fight against infection and also cancer development. Now, this protection rather, depends on having normal numbers and ratios, different mature circulating white blood cells. So you have to have a certain number of white blood cells in order to provide adequate protection. When any white blood cell is too many in number, whether it be too high or low, immunity, gas exchange, and clotting become compromised. And this leads to complications, to a lot of different complications and whatnot, bleeding being one of them. Leukemia is classified by type of where it originates. For example, cells from the lymphoid pathway are referred to as lymphocytic or lymphoblastic. Lymphoblastic. And those from a myeloid pathway are referred to as myocytic or myelogenous. And as I said, these are just subtypes, and there are, of course, other subtypes. In leukemia, cancer most often occurs in stem cells or early precursor lymphocyte cells. So before the lymphocytes become full lymphocytes, the precursor cell, before it becomes full or grown or mature, this is what leukemia mostly affects. Now, what happens is that this will lead to excessive growth of specific types of immature leukocytes or white blood cells. An overproduction of abnormal cells in the bone marrow can lead to the reduction of normal blood cells, which can ultimately lead to anemia, Remember, because red blood cells are made in the bone marrow, but the overcrowding with the immature cells will cause a reduction in red blood cells, so leading to anemia. Also leading to thrombocytopenia, which is platelets, a low platelet count, because again, overproduction of those immature white blood cells. And also leukopenia, which is low white blood cells, the more normal types. And so when you think about these particular issues here, just think about the lab test that we would generally obtain, which is a CBC, and it can actually show you anemia, thrombocytopenia, and leukopenia. When you see these penias on the end, it just means a lower counts, as opposed to cytosis, like thrombocytosis. That would refer to an increase in number. And here we're talking about a low count. These white blood cells are immature and abnormal, and as I said, they're known as blast cells. They're significant. They become significant in number, and they do not provide the protection against infection that white blood cells are supposed to. Leukemia cells can be found in the spleen, the liver, lymph nodes, and also the central nervous system. In acute leukemia, changes occur fast, and without the right treatment for these patients, it will eventually lead to death. And these patients typically die from hemorrhage and also infection. As far as etiology and genetic risk, there's no known etiology, but possibly, or what scientists lean to, is genetic and environmental causes. In leukemia, the problem involves damage to genes that controls cell growth. And this leads to a loss of a normal cellular regulation. And of course, this leads to damage to these cells. They go from normal to malignant or cancer cells, essentially. That's what cancer is. It's just basically abnormal cells due to cellular regulation issues. As far as risk factors for leukemia, patients who receive radiation or exposed to radiation, viral infection, and exposure to chemicals and drugs, etc. So there's some additional information for you to read there. Some causes of these causes, as I mentioned, the radiation, the chemicals rather, drugs, also from chemo drugs can also cause this condition. Patients who are more at risk, those who have Down syndrome, Bloom syndrome, Klinefelter syndrome, and also Fanconi's anemia. These patients have more increased risk. Now, as far as incidence and prevalence of this disease, more than 60,000 people in the U.S. develop leukemia. This accounts for about 3 to 4% of all new cases of cancer. So let's go ahead and get into some of the signs and symptoms these patients will have because of leukemia. It will take an interprofessional team and family and social support in order to successfully manage this condition and treat it. We will be talking about how the signs and symptoms impact the cardiovascular, respiratory, intestinal, and central nervous system. Also, as far as laboratory assessment, the definitive test to determine if someone has leukemia is to do a bone biopsy or a bone marrow aspiration and study it under a microscope. Let's see, I actually had to record this over because I think I messed up something. As far as looking at history, we want to look at the patient's age, genetics, predisposition, the jobs or hobbies they have, which could expose them to some chemicals, if you will, exposure to radiation. Also, we want to talk about any previous illnesses these patients may have experienced. Also take a look at chart 40-5 for the impact of leukemia that it has on our systems. As far as cardiovascular changes, as an example, these patients may have orthostatic hypotension, palpitations, an increase in heart rate. Also, because the white blood cells, there's so many immature white blood cells in number, it causes the blood to become highly viscous or thick. And therefore, the patient's blood pressure is normally pretty high with a bounding pulse. And go ahead and read some additional information in this section about this. Also, these patients have respiratory changes due to decrease in gas exchange from anemia and infection. Remember, the white blood cells are immature, so they're not functioning fully as a defense mechanism, if you will. These patients are short of breath with exertion, that's DOE, or dyspneic with exertion. There's an increase in respiratory rate due to severe anemia. There's coughing and shortness of breath with respiratory infection. And there's also abnormal breath sounds. As far as GI, these patients, they may have bleeding gums. They also may have weight loss. As far as skin changes, there's pallor and coolness to touch of the skin due to decreased perfusion from anemia, pallor of the face, around the mouth, and nail beds. These patients also may have petechiae anywhere on the skin, especially the legs and feet, and failure to heal wounds, and also gum bleeding. As far as central nervous system, they become fatigued, headache, they experience fever, papilla edema, seizures, and also coma. There's also an increased risk of infection due to immature cells, which I already mentioned. Ask patients about infections. Platelet functions also abnormal. And so there's a risk of bleeding. So look for nose bleeding, rectal bleeding, as well as hematuria. There's some additional information there. These patients have weakness and fatigue from anemia and they also have an increased metabolism of leukemia cells. So you want to ask about headaches, if they have a decreased attention span, muscle weakness, and also anorexia, and there's also some additional information there as well. We want to look at the last 24 hours of activity history to determine these patients' activity and tolerance. So look at the past 24 hours to determine this, not the past week, 2 weeks. It's easier to remember 24 hours rather than what you did last week. Leukemia also affects all blood cells. This affects all organs and systems. So it's a systemic has a systemic impact on our bodies. And as far as laboratory, patients with leukemia, they have a low H&H, platelets, abnormal white blood cells. White blood cells can also be low, normal, or elevated. But those patients who mostly have blast cells upon diagnosis or analysis of their blood typically have a much more poorer prognosis. Clotting times are also abnormal. These patients have a decrease in fibrinogen, and other clotting factors are also common. There's also a chromosome analysis identification of these abnormal cells that can be done as well. Specific signs and symptoms will determine the type of imaging that needs to be done. For example, if a patient has shortness of breath, a chest x-ray would be done to determine if the leukemia has infiltrated the patient's lungs. Same with if they have maybe mental status change, then you might do an MRI of the brain, a CT of the brain, to see if the leukemic cells have infiltrated brain tissue, if you will. As far as priority collaborative problems for patients with acute myelogenous leukemia, or AML. The most common type of acute leukemia seen in adults include potential for infection due to decreased immunity and chemotherapy. So they're at risk for infection. There's a potential for injury due to poor clotting from thrombocytopenia and also chemotherapy. There's also fatigue due to decreased gas exchange and increased energy demands with these patients as well. Now, as far as prevention of infection, infection is a major cause of death in the patient with leukemia because white blood cells are immature and or depleted. We'll also talk about different drug therapies, i.e. induction, consolidation, and maintenance therapies. Also, another treatment that we talk about is hematopoietic stem cell transplantation, and also talk about minimizing injuries and conserving energy as well on this particular slide. As I mentioned, infection is a major cause of death for these patients. Also, chemotherapy contributes to that as well because chemo depletes the good stuff as well, good blood cells. This eventually leads to sepsis, which of course they can die from. The most common sources of infection will come from the skin, the respiratory tract, and also the intestinal tract. So these are some common sites of infection when patients have a compromised immune system from leukemia. Infection can also occur from the patient's normal flora. Remember, human beings have their own normal flora. For example, E. coli can be found in our GI tract. Or also, infection can occur from other people or the environment as well, as I'm sure you know. Gram-negative bacteria is the most common cause of infection for these patients. Also, take a look at chart 40-6 for a list of areas to assess for patients at risk for infection. Now, getting into drug therapy, I talked about induction, consolidation, and maintenance therapy. So let's just talk about induction therapy and what this entails. It is an intense combination of chemo started at the time of diagnosis. And the purpose of this treatment is to achieve a rapid and complete remission of all disease signs and symptoms. These patients are at risk for neutropenia. And so recovery of their bone marrow function requires about 2 to 3 weeks to protect the patient from life-threatening infection. Side effects of drugs will be nausea, vomiting, diarrhea, alopecia. These patients might have stomatitis or mouth sores. They also have kidney, liver, and cardiac toxicity from these drugs. Older patients are at greatest risk of death during this particular treatment phase, the induction phase. So the next treatment or phase is consolidation therapy. This one consists of either the same drugs used for induction, but at different dosages, or a different combination of chemotherapy drugs. This treatment occurs early in remission with the intent to cure the patient. During this phase, the stem cell transplant may be required during the consolidation phase. The next treatment therapy is maintenance, treatment that is prescribed for months to years after successful induction and consolidation therapies for this condition. The purpose is to remain in remission that was achieved through induction and consolidation therapies. Now, as far as the hematopoietic stem cell transplantation, it is used to treat patients with leukemia who have closely matched donor and who is in temporary remission after the induction treatment. Now, the bone marrow is the actual site of production of leukemic cells, and so it's difficult to eradicate all cells during induction. Hence, additional chemotherapy is given with or without total body irradiation in order to purge or to clean the bone marrow of leukemic cells. After this cleaning of the bone marrow, transplant must be done. Otherwise, this patient will die from infection or hemorrhage, because remember, they don't have any of these blood cells now because you've cleaned out the bone marrow and basically starting from scratch, if you will. After these cells go into the bone marrow, then hematopoiesis begins, and then normal and hopefully properly functioning blood cells will occur. And of course, the goal is permanent cure. Now, transplantation has 5 phases. That is the stem cell obtainment, there's conditioning regimen, transplantation, engraftment, and also post-transplantation recovery. So take a read at those terms, concepts. As far as infection or protecting the patient, of course, number one on this list is thorough hand washing. Staff members who have upper respiratory infection need to wear masks when caring for these patients. We do want to observe strict asepsis with dressing changes or when accessing central venous catheters. We also want to maintain strict aseptic technique and care of all of your catheters and lines and IV accesses, if you will. Patients should be in a private room, and this will reduce cross contamination. You do not want any vases, however way you say it, with standing water in the room, or standing water in denture cups or humidifiers in the patient's room, because they are breeding grounds for organisms. Some patients who are immunocompromised are placed in rooms with a high efficiency particulate air filtration system, or HEPA filtration system, or laminar air flow system. And this basically decreases the number of airborne pathogens, so providing the patient with more protection. We want to observe the patient's labs, CBC with an absolute neutrophil count, or ANC. We also want to observe the patient's mouth every shift for lesions and mucosa breakdown. We want to auscultate their breath sounds for crackles and wheezes. We want to also look at their urine for odors and cloudiness of urine, and also assess for urgency of burning or pain upon urination. We want to also check their vitals at least every 4 hours for fever. Now, I mentioned ANC. When a patient is what we refer to as neutropenic, it means their absolute neutrophil count is less than 500, and when they are, they're placed on neutropenic precautions. As far as minimizing injury, patients with limited platelets are at risk for bleeding due to poor clotting with minimum trauma. Limited platelets also can occur during the induction treatment phase. Remember, because these drugs are destroying the good stuff. We want to maintain the patient's H&H. We want them to be absent of visible bleeding, petechiae, or ecchymosis. We want an absence of evidence of occult bleeding, like abdominal swelling, or tarry stools. These patients are at risk for bleeding if the platelet count is less than 50K, and spontaneous bleeding if they're less than 20K. So it becomes even a more urgent matter when it falls below 20K. I want you to also look at chart 40-7 for patients with thrombocytopenia. We want to observe for bleeding. We want to assess every 4 hours for evidence of bleeding. Look for oozing, enlarging, bruising. You may have to take a skin marker and draw around the bruise. So if it expands beyond that point, we know that the patient is continuing to bleed. Also, we want to observe for petechiae and also purpura. Inspect all stools and urine, all drainage, and measure the patient's abdominal girth daily for possible internal bleeding as well. So they should provide you with some measuring tape. You want to measure the patient's abdominal girth. Now, platelets typically return to normal much more slowly than white blood cells and red blood cells. These patients might need platelets and red blood cell transfusions if they are low. As far as conserving energy, because the patient has low white blood cells in leukemia, which causes anemia and fatigue, these patients may not have any energy. Now, leukemic cells have a very high rate of metabolism. I mean, you think about the normal white blood cells, it has normal metabolism, but in these cells, the metabolism rate is much more higher. Remember, there's this cellular regulation impairment that is going on. And this does lead to fatigue in these anemic patients. Interventions to reduce fatigue focuses on conserving energy and improving the red blood cell counts, as I just mentioned, the transfusions. Adequate nutrition with calories to meet basal energy needs. Provide small, frequent meals with high protein and carbohydrates. That's what that CHO is carbohydrates, and the CHON is protein. It's a chemical element. See chart also 40-8 for how to conserve energy. Make sure you read that. Blood transfusion increases the blood oxygen carrying capacity, and it does replace red blood cells. As far as drug therapy, provide colony-stimulating growth factors, which reduce the severity and duration of anemia and also neutropenia. Now, erythropoiesis stimulating agents or epogen increases production of red blood cells. There are side effects to this drug, a few of which are hypertension, heart attack, fever, myalgia, rash. These drugs are given when the hemoglobin is less than 10 milligrams per deciliter. As far as activity management, to help conserve energy, we want to organize activities that will ensure the patient can rest adequately. I think that's it on that slide. Now we want to get into care coordination and transition management. Remember, we always want to prepare these patients to go home, but that care must be coordinated very well. And so we will be discussing home care management, self-management, education, and under that subcategory of psychosocial preparation and also healthcare resources. We always want to stress the importance of follow-up. Discharge planning with these patients begin as soon as remission is achieved. These patients might need a home health care nurse for dressing changes, for your central lines, infusions, or to just even answer questions. Some chemo is given at home with a home health care nurse. Patients who develop sepsis and vascular occlusive disease may have to be readmitted. As far as self-management education, I want you to look at page 826, chart 40-9 for care of central line catheter. These patients should be taught how to protect themselves at home from infection, taught about proper hygiene. They should be avoiding crowds or others with infection. These patients cannot receive a live virus inoculation, such as poliomyelitis, measles, or rubella, for about 2 years after they receive a transplant. A stem cell transplant. Generally speaking, patients receive no vaccination for the first year of the transplant due to the fact that their immune system is not strong enough. They cannot generate the antibodies this early after the transplant to fight against the offending organism. Also see page 827, chart 40-10. preparing for self-management. Also teach these patients to notify the physician or healthcare team if they develop a fever. These patients at risk for bleeding, they're at risk for bleeding due to platelet recovery being slower than recovery of other cells, and clotting remain pretty low. So reinforce, because of this, you want to reinforce safety and bleeding precautions, which should stay in place until the platelet count is greater than 50K. Teach these patients to assess for petechiae, to avoid trauma, to be careful in using sharp objects. They should also apply pressure. That's what the PSI means. Pressure to wounds for about 10 minutes if they have a cut or something. So apply pressure for a much longer period. They should teach them to report blood in the stools and urine. Also, if they have a headache that is unresponsive to Tylenol. As far as psychosocial preparation, refer to organizations like American Cancer Society and Lymphoma Society of America. We want to also advise those who are severely fatigued to participate in exercise, as it will help to reduce this fatigue, but this should be low impact exercise. As far as healthcare resources, these patients might need a home health aide, a home health nurse, post-hospitalization. They may need help with ADLs, ambulation. They need assistance with financial resources. We want to refer them to social services to ensure that their insurance is adequate and that it will pay for these services. Patients who are uninsured can be referred to drug company-sponsored compassionate aid programs and also local cancer center foundations if they don't have insurance. We also want to explore the need for transportation for follow-up care, evaluation. These patients will, as far as evaluation, these patients will remain free of infection and sepsis. They will not experience episodes of bleeding. We also want to ensure that they balance activity with rest, don't overdo it. And also they should be shown energy conserving techniques, which means they may have to be referred to OT, PT, who can actually provide some insight on what they can do to conserve their energy. And that concludes my presentation on leukemia. And so this part we don't have to go into in class, so just make sure you take a listen to this as well. Thank you.